My name is Dario Gostin, and today I'm doing my presentation on Parkinson's disease. Parkinson's disease is a progressive degenerative disorder that usually occurs after the age of 60. It occurs when irreversible changes happen, primarily to the brain's gray matter, which leads to impairment of the extrapyramidal motor system. Due to these changes, a decreased level of dopamine is secreted, which causes an imbalance between the excitation and inhibition, eventually leading to rest and tremors, stoop posture, muscle rigidity, shortened and shuffled steps, as well as other involuntary movements. The patient is a 63-year-old patient that identifies as female, lives in the Cree Nation, and reports resting tremor in the left hand, arm stiffness in the past 2 years, and reports falling more frequently, difficulty walking, initiating getting up from the chair, as well as walking. And the patient stated that once she starts walking, she finds it difficult to stop. Now, she has taken medication for the last 2 years, but she said now that the tremors and the stiffness are worsening in all four limbs. Upon inspection, we noted that the pin rolling tremor in the left hand disappears when the hand is engaged in movement. Slow, fine, rapid movements are noted in both hands with rigidity to both arms. Noted that the patient has stooped, forward leaning, shuffled gait, and muscle rigidity and stiffness in all four limbs. It's noted that the lack of balance is after 10 seconds and it's during the lumbar test, as well as noted that the patient's words sound muffled when she speaks, and that the patient speaks in a quiet tone, often difficult to hear and somewhat hoarse. The patient also reports constipation as well as a history of asthma. For further assessment, a full chem as well as CBC was taken, which all came back normal. And this is to rule out any other diagnosis that may be causing these issues, as well as any infections. Full vital signs was also taken, which came back normal. The BP is slightly elevated, but there's nothing to be concerned about. As well as a full list of medication was taken, and then a new order of cinnamon was given, and the patient was also referred to speech language as well as PT. There's no real diagnostic test for Parkinson's disease. Now, lab and imaging tests may be completed to rule out other diagnoses like seen in this case study. The neurologist usually will diagnose PD based on the patient's history, a physical exam, and presenting signs and symptoms. Signs and symptoms could include, but are not limited to, tremors, bradykinesia, rigidity, positive response to anti-Parkinson's drugs, fast-like faces, stoop posture, arms flexed at elbows and wrists, short shuffled steps, as well as hips and knees slightly flex. And you can see here that these are the 5 things that the patient did present with today. Risk factors for this patient that are modifiable are the environment, which is around like toxins and viruses like carbon dioxide, as well as some pesticides, as the patient does live on a native land. And then some non modifiable risk factors include the age, as the patient is above 60, as well as the biological sex, as men are more at risk than women. Other systems that is affected by Parkinson's disease. One is the MSK system, which include the tremors, the stiffness, the slow body movements, muscle and joint pain, muscle loss, and then the incapability to swallow or speak due to muscle control and the lack of their in the throat, as well as the respiratory system, which is one of the leading cause of deaths in Parkinson's disease is due to the respiratory system. And respiratory infections are very common, as well as respiratory muscle weakening, difficulty breathing, as well as upper airway obstructions, and then any abnormalities there. For nursing diagnosis, the first one will be risk for injury related to diagnosing the diagnosis of PD, and it's evidence based by the patient reporting more falls as well as bradykinesia. Now, the rationale for this is the top priority as it is a safety concern. As nurses, we aim to keep the patient safe and to reduce harm, so we must adjust this first before addressing any other diagnosis. The second one is the impaired physical mobility related to the tremors and the rigidity as evidence based by neuromuscular impairment. Now, the rationale for this is that the patient's safety concern is related to her impaired mobility, as well as her tremors and her rigidity, which make movements and balancing harder. So, in order to address the risk for injury, this will also be addressed at the same time. For the short-term goal for this patient, the patient will show signs and symptoms of reduced tremors and rigidity 1 hour after taking the scheduled Cinnamate. Now, for the rationale, the therapeutic outcome assessment is an absence of involuntary movement. With the onset of this drug being unknown and the peak time of 1 hour, reevaluating the patient around the peak time is best to ensure the therapeutic effects of this medication have taken to effect. Normally, we will do a reassessment about 20 to 30 minutes, but since we don't know the onset, it's best to do it around the peak time. For the long term goal, the patient will gradually increase neuromotor exercises to 30 minutes a day within 3 months of being referred to PT and OT. For rationale for this, neuromotor exercises will help improve and maintain the patient's physical function and reduce falls. For the first intervention, the nurse will administer the scheduled sediment throughout the day as per the MAR. For rationale, administering of this drug, which is a combined drug, is proven to reduce involuntary movements. The first half of the drug is levodopa, which is the drug that helps passes through the blood-brain barrier and converts to dopamine in the patient's brain. The second part helps the prevention of the dopamine, which is essential as dopamine is a neurotransmitter that helps the balance between excitation and inhibition that we've seen in the Patho. The second intervention is that the patient will participate in daily PT and OT that will gradually increase her motor skills with assistance from PT, OT, a nurse, or at home support, such as her partner or family that can also help her. The rationale for this is working on their motor skills, such as the gait, coordination, balance, and participating in activities such as yoga is proven to help decrease the rate of falling and improve physical functions. A few help teachings that I will do. The first one is to teach and instruct the patient to take the new medication exactly as prescribed and to report any adverse side effects such as twitching, eye spasm, grimacing, or any personality changes. The second one is to teach the patient and the family about fall prevention methods and how to move around the home safely. So, this would include educating the patient as well as the family on safety measures such as grab bars, decluttering, removing everyday items from high areas and bringing them lower, and avoiding carrying things around while moving around. This teaching strategies that I will do is just building rapport with the patient and the family, inquiring about the previous knowledge of the disease, just to get the baseline there, and then creating a safe, blame free learning environment for the patient. We will also do teaching that can be done in a group session, one on one sessions, written pamphlets, videos, as well as the teach back method. For the evaluation of this goal, for the first one, after 1 hour of the administration of the medication, decreased involuntary movements and tremors were noted to the patient. For the evaluation, the nurse will perform a neuro and an MSK assessment immediately before and 1 hour after the administration of the medication. The nurse will then compare both assessments to determine if the patient met the short term goal. If the intervention were unsuccessful, the patient will be referred back to the doctor to discuss the possibility of increasing the prescribed medication. For the second goal, it was also met as well, as after 3 months, the patient can complete 30 minutes of neuromotor exercises daily. To perform the evaluation, monthly check-ins with PT will determine if the patient is on a trend to complete the goal. The patient should start with about 10 minutes of exercise in the first month and gradually add more time to increase it until it reaches the 30 minutes. At the end of the 3 months, a nurse, PT, OT, or even the patient's partner can evaluate the goal's outcome by timing how long the patient can complete neuromotor exercises in a day. If the goal was not met, the patient's goal could be adjusted to provide more time if needed. Also, the medications the patient is on can be reassessed. The patient can be reevaluated from PT and OT, and a new goal can also be discussed based on the patient's needs and realistic outcomes from where the patient is now at this moment after the 3 months. Here are my references, and I do want to thank you for listening to my presentation on Parkinson's disease.